So, Nankri Nangi, welcome everyone to our Riverland Academy of Clinical Excellence Grand Round for August. It's fabulous to see people coming again to learn from experts from around the world, to open our minds to different ideas, to different thoughts. And today, we have the opportunity to be thinking about, well, what does it mean when we're talking about health needs? What does it mean when we're talking about our services trying to make an impact on health outcomes? And how can we look at our relativities in Riverland Mallee Coorong, say, compared to other regions in Australia, compared to other regions in the world? Well, there are people that have done work on this, and that work is often framed in terms of the burden of disease. And we're very fortunate to have an expert in that field of study with us today, and an expert who has an association with our LHN. Dr. Felix Ogbo is a senior lecturer in public health at the University of Western Sydney, and in actual fact was a senior lecturer prior to joining the Riverland as a GP trainee. He is now continuing his general practice training and is engaged with us in our public health unit. So it's great to see that health clinicians increasingly are not coming as blank slates. They're bringing skills at the same time as learning new skills. And Felix is certainly a fantastic example of that, having international expertise in this area and learning the art of rural generalist practice locally. Welcome to hearing what we can learn about the Australian Burden of Disease study.
Thank you, Paul. Thank you, everyone, for your time and for joining me to kind of listen to what I have to say. So, like Paul said, I was involved in the global burden of disease when in my former job, and it is something I did for, I think, close to 5 years. So today I want to talk about the Australian Burden of Disease Study 2022 and what the findings, as well as looking at it more broadly, what that has to do with our region in the Riverland. So by way of an introduction, from the year 2000 to 2015, we had the Millennium Development Goals, and they played an important role in improving the health outcomes more globally, especially in developing countries. And in 2015, the United Nations General Assembly proclaimed the massive and very ambitious SDG, which we call the Sustainable Development Goal. The aim of the MDG and the SDG really was to, it is to galvanize global and political and developmental response to the threats to population health and well-being in both developed and developing countries. However, one could argue that key aspects of the SDGs are largely designed for developing countries, especially if you look at ending poverty, ending hunger, ensuring health and well-being, quality education, clean water and sanitation. There are some of these key aspects of the SDG are mainly for developing countries. Of course, you could argue as well that the climate change focus, of course, that is more global. Of course, the SDG agenda, if it is well implemented, we know that many lives, including those of women and children under 5, would be saved. The question is, how then do we save life or improve population health? The assumption is we cannot save lives if we do not know what people are dying from. And there is often this statement that we throw around in the global health arena, which is no data often means no disease burden. What you cannot measure, people wouldn't want to listen. In developed countries, we do know that diseases are often counted, they are often tracked, And these results, most of the time, inform decision-making. However, the picture is different in developing countries where more than 70% of disease burden, that word disease burden, I'm going to define that. That is why I have highlighted that word disease burden, or the burden of disease. And we know that some of these do occur because in developing countries, there is poor disease surveillance. However, more recently, we are now seeing decision makers, those in government, those in agencies, using findings from analysis of in-country surveys, areas where you don't have data at all, or areas where you have limited vital statistics, or even published data, that they're using some of this information to prioritize health focus areas. And what gave birth to some of these is the Global Burden of Disease study. So before I come into what the findings of the Australian Burden of Disease 2022 study is, I want to take us back a little to look at things more globally, and then we come into the national picture and we finish off with our region. So the question is, what is the Global Burden of Disease study? It is a systematic and a scientific effort to quantify the comparative magnitude of health loss due to diseases, not just diseases, but also for injuries and risk factors by age, sex, location, and over time. What is the burden of disease? This is often, lost in the scheme of things. It is an analytical method of measuring the impact of diseases and injury in a population. It is the difference between a population actual health and its ideal health, where ideal health is living to old age in good health without disease or disability. The phrase burden of disease is often measured using a metric called the disability adjusted life years, which we call DALY, aka or also known as the total burden. So if I say the burden of HIV in Africa is XYZ, then it means that I'm talking about the disability adjusted life years for HIV in that specific location and also in that specified time period. There is the underlying rationale in GBD, which is the global burden of disease, that everyone deserves to live a long life in full health. Therefore, by providing a comprehensive picture of what disables people or what kills people across country, over time, across age group and sex, the GBD is able to show us what prevents us from achieving this specific goal. Global burden of disease focuses on a number of health focus areas. They can provide us data on mortality, data on the incidence and prevalence of diseases. Also, these are some of the concepts I want to kind of highlight to us in this presentation. Some of us might be knowledgeable in terms of this concept. The years of life lost to premature death. In Australia, currently, if a child is born, male or female, we expect that that child should live close to 85. For a female, I think around 86 or 84 years. For a male, we expect that person to live up to 82. However, if something happened, maybe at age 70, the person dies, then we would say the extra 10 or 15 years would be the years lost due to that premature death. And the next one is the years lived with disability. We know that not everyone would live, a full year without not maybe having a flu or not visiting the GP or not visiting the hospital. So that time spent being sick, off work, or injured due to maybe injury to the shoulder or the ankle or the limb, then that would be years lived with disability. The addition between the years YLL plus the YLD gives us the disability adjusted life years, which is years of healthy life lost. So why do we do this research? I found this quote from Bill Gates very, so nice. That he said he's quite often amazed by the disconnect between what we see in the news and the reality of the world around us. So if you look at this graph, you could see the first one is actually the causes or the cause of death in the US in 2016. The number one is heart disease, followed by cancer, and then followed by road traffic accident. If you compare that to what people actually look at on Google, the focus mainly is on cancer and then on the road traffic accident. If you go on to what is largely being reported by the media, I've taken out the comparison on the Guardian as well, but what I'm showing here is for the New York Times. The focus, what they report more, is on homicide and terrorism. Only 2.5% of the coverage is actually on the number one cause of death, which is heart disease. So that kind of tells you the disconnect between what happened in the data and also what we are presented with all the time. So why do we do research? Why is some of these epidemiologists involved in crunching the data and looking at some of these? We think their decision makers need a comprehensive and comparable picture of diseases, injuries, and risk factors that impact health across time, sex, and ages. They use this picture to best allocate, I would say, scarce resources, to target interventions, and to set targets. And of course, this is done to improve population health. The first global burden of disease originated in 1991, developed by the World Bank and the WHO. And at the time, this was to address critical information and to provide evidence for cost-effective intervention. Preliminary results of those analyses were first published in 1993 and subsequently published in 1996 and in the Lancet in 1997. Who uses evidence from the global burden of disease? A lot of organizations that we know already do use some of the data from the global burden of disease. The World Health Organization, the NIH, the Bill and Melinda Gates Foundation, the USAID, the World Bank, a lot of other organizations. If you go to developing countries, this was in Colombia, where the mayor of one of the districts in Colombia actually used data from the global burden of disease to reduce homicide in his region. In the Philippines, this Dr. John Wang also used evidence from the GBD as well to set priority areas in the national health resources. In Mali, Dr. Samba So also used evidence from the GBD as well to secure funding for HIV, Haemophilus influenza type B vaccination in his country. So I want to just spend some time to highlight some of the key terms and concepts that I want to kind of discuss in the Australian Burden of Disease Study 2022. I've highlighted this before, which is the disability adjusted life years. On the left-hand side of your screen, you could see when a baby is born. That is today, 2023. We expect that baby to live based on data on life expectancy. We expect that baby to live, if it is male, 82 years, female, 84. I think the Japanese, if you were born in Japan, for a female, I think around 86, 87 years. But we know that he starts school, he gets an A, he gets married, have kids, and gets old using a walking stick. So the number of years of healthy life lost due to premature death, disabling illness or injury, we refer to that as the disability adjusted life years, which is also called DALY, aka total burden. The key concept again is not all people are in perfect health in all their entire life. Some, even though someone is born today in Australia, acknowledging that the life expectancy is around 82 years for a male, we know that not everyone will live up to 82 years because some people would, there might be disease, COPD, heart disease, dementia that will come into the picture, and the person may lose their life before that 82 or 83 years. In between, flu, illness, injury at work, all of that will come in as well and will also take a toll. So, like I said earlier, DALY equals YLL plus YLD. What is YLD? It is the summation, the number of years of life spent unwell. So if someone calls in sick, those days, those months are added up, and that forms the YLD, the years lost to disability. And the years, YLL, the number of years of life expectancy remaining at the time of death. So what are the findings from the Australian Burden of Disease study? Number one, the proportion of the total burden, when I say fatal burden, I'm also talking about the YLL, and the non-fatal, which is the disability, years of life lost due to disability. Over time, Australia started collecting data on some of these key concepts in 2003, and they've done until 2002. You can see that in 2003, there is actually more people that died prematurely, which was 53% compared to 2002, which is now down to 48%. There is also an increase in the number of people spending more time in ill health, which is living their lives with disability over time as well. So there is, of course, these are standardized by age, looking at the DALYs, the YLL, and the YLD over time. There is an increase, which we've also been talking about. I guess a number of people have raised some of these findings in the media as well. I guess also the politicians have used this to, I guess, increase the retirement age in this country, where we know that Australians are living longer. The question is, are we living healthier? We would answer that question in the next 2 or 3 slides. So there is a change in the number of people dying prematurely and the number of people living with disability in this country. This also looks at the proportion of the total burden again, which is the DALY, fatal, YLL, and the non-fatal YLDs for the leading 5 disease groups in 2022. Cancer remained a number 1 killer in terms of, taking people prematurely. Musculoskeletal diseases such as back pain and its problems is causing a lot of people to live with disability in this country. Mental health and substance abuse, another major source of YLDs in this country as well. Cardiovascular diseases, there is a change in that direction as well, where we know that the number of people dying from cardiovascular disease and neurological diseases have reduced, and also people living with disability due to cardiovascular diseases and neurological diseases has also increased over time. And of course, one could argue that this is due to improvement in treatment, improvement in preventative educational messages, also improvement in people seeking health early. So in Australia in 2022, what are the top 5 leading causes of DALYs in this country. Number one is coronary heart disease. Two is dementia. Three, back pain and problems. Four, COPD. Five, anxiety. With back pain, I was a little surprised when I saw that, but I guess looking at my personal experience as a GP, I realized that, oh, yes, I think it is up there because most of the people one will see will be relating to back issues as well. So I had no issues when I saw this information. So one can also compare in 2003 and 2022, what has been the changes over time. We know that there has been a reduction in the number of people being disabled from heart disease, stroke, lung, bowel, and breast cancer, and rheumatoid arthritis as well. There has been a significant decrease in the number of people being disabled from or losing their lives from dementia. And of course, this is partly due to changes in the death code for dementia. There has been an increase in suicide and self-harm injuries, musculoskeletal, type 2 diabetes, and COPD. So in the global burden of disease, one can actually compare what the changes are over time for each country. You could compare Australia to, for example, the Philippines. You could look at data for Nigeria. You could look at data for China. All of that is quite interesting when you visualize some of this data in the Global Burden of Disease website. But in Australia, one can just look at this picture and say, okay, this has what has happened so far. If you look at road traffic accident, I don't know if anyone can see that here. It has fallen dramatically, especially in the GBD, where you could compare from 1990 to 2022. You could see a significant reduction in the number of people dying from motor vehicle accident. In other countries, of course, in developing countries, you can also see that mismatch happening as well in relation to some of these conditions. So if you can also make changes to this when you want to compare by age or by sex. In this country, if you want to look at those children under 5 years, you will see prematurity as the number one. But if you go to a country, say, for example, Nigeria in Africa, you would see possibly malaria or upper respiratory tract infection and or diarrhea. So here's, of course, I remember very clearly that Joe Hockey, when the former treasurer, when there was this issue around increasing the retirement age from, I think, 63 to 65 or so, or 65 to 67, there was this argument. Australians are living longer. Australians are living longer. But the real thing, looking at the data, is little has changed in the proportion of life spent in full health. Even though we're living longer, the proportion of people living with disability has increased. So Australians are on average living longer and spending more years in full health, meaning no diseases or injury. So the years lived in full health is also referred to as year adjusted life expectancy health. However, years lived in ill health are also increasing, resulting in little change in the proportion of life spent in full health. Quite interesting when I read this, and of course, one could argue that this is driven by a number of some of these issues as well, where you know that we've prevented premature death. However, people are still living in disability as well. So, what are the implications of some of these findings, looking at it from the global perspective and within the in-country view, in particular, the Australian system? What are the implications of some of the findings for our region? I have 3 key points, which I've highlighted before, which is no data often means no disease burden. And I think we need to improve our data collection, analysis, and dissemination of those data through, for example, that can be through publication, through reports, or through conferences and or seminars. My understanding is the region or the LHN is making efforts on data gathering. There is a lot of resources now being put into improving data collection and analysis. So I think that is the right step in the right direction, because it is often difficult to, to tell people that we have this disease burden when you can support that with data. 10, 15 years ago, I don't think in my widest imagination that there is something called bachelor or master of data science. But more recently, we're seeing colleagues or friends who are now majoring in as data scientists and doing good works in that domain. Number two would be research and evidence-based results should drive the LHN guidelines and policies. And I know that Paul and a few colleagues are pushing for more research, more evidence in our LHN as well. And if I flip back to, I guess I do some work in the emergency as well, there is now a push to have guidelines that are evidence-based, not just, an expert sitting somewhere to write some of these guidelines, but looking at using evidence-based reports to draft some of these guidelines and policies. And number three, I think it will be wise and also very nice to prioritize resources using locally generated data to set targets and health focus area to drive our agenda in the LHN and in the region. So to conclude, I often is very fond of Mark, and he was fond of saying that there are three kinds of lies. We have the lies that it is there. We also have the damn lies. And of course, number three, the statistics, which is oftentimes the data. And famously, former Director General of the WHO would often reply that what gets measured gets done. Thank you. My references?
So, Felix, thank you so much. What a challenge to a health system that is in many ways historically funded by process and by procedures that have been done, assuming that patient choice reflects the burden of disease and the priorities, which of course we know isn't always the case. Neither providers nor patients, if they're not informed by data, are going to necessarily be making choices about health resource utilisation and provision out of thin air. It strikes me too that if you looked at those figures, there were some areas that were increasing in their impact on DALYs. Particularly, I noticed that dementia, diabetes, and suicide all effectively had doubled their disability-adjusted life years, and they clearly are areas that our LHN is addressing. But from your experience, and again, this becomes difficult because as an LHN, we are funded through the state. A lot of the disability-adjusted life years are going to be best addressed in primary care rather than in hospitals. But a large proportion of everyone's budget is spent in hospitals. From your experience, are there areas of data that we do need to be collecting that we aren't at the moment that could guide better resource allocation?
Yeah.
What data do you think is accessible but potentially not being used at the moment that could help guide our resource utilisation?
So I guess my understanding is there is a lot of data collection in the hospital. The question is whether or not we are collecting data outside of the hospital. The main example that I can recall is data on mental health. There was a study I was going to do in Bamra while I was working there. It relates to mental health. And there was a recent report by, I can't recall the full name of the report now, but there was the people who wrote the report agreed that they can't make any informed decision because there was no data on depression, there was no data on anxiety, there was no data on anything. Therefore, they cannot make any informed decision on what is happening in the community in relation to mental health. So there is evidence, there is good data in the hospital. The question is, out of hospital, is there evidence coming from those areas? Because we know what drives dialysis often will come from out of the hospital. So if we don't have data out of the hospital, I guess it then becomes very difficult to address some of the things that are driving up the dialysis or the YLDs, and or is it kind of does not help us if we have to keep people out of the hospital and or address some of the risk factors that drives some of these diseases, injuries, and or risk factors. So if I have to conclude, I think there should be a push towards data collection, data gathering out of the hospital and in the primary care as well, to have some of these improvement done as well.
Thanks, Felix. That's very helpful. Any other questions very quickly from listeners? Dr. Mendham. Amy.
Hello, thank you for the presentation. That was really nice. My question is around how you incorporate multimorbidity into the burden of disease and how that then would affect, I guess, Paul's question regarding resource allocation.
So in the Australian burden of disease, I think over 200 disease burdens, over 200 types of diseases were analyzed. In the global burden of disease, I think they do analyze around or estimate for over 300 disease burden and risk factors of over, I think, 200 as well. But if we're looking at the cause of death, there is often this assumption from the global burden of disease where we say one person can only die from one particular cause of death. So if we're looking at mortality, even if someone has an acute myocardial infarction, has a stroke, has COPD, is a smoker, if I'm to code that person's cause of death, I can only say this person died from acute myocardial infarction and or died from stroke. So if I'm to look at someone with comorbidity, I can only address one cause of death. However, if I'm looking at the risk factors, then I can look more broadly as to how can we ensure that this person lives in a way in full health. Then I will be addressing all of the risk factors for each of those diseases. Does that make sense?
Yeah. Thanks, Felix. Excellent question. Your research on metabolic syndrome, to me, Amy, seems to underpin at least 75% of the causes of the top causes of death in the DALYs or the burden of disease. If you look at diabetes, stroke, cancer, cardiovascular disease, which often coexist, as you say, in multi-morbidity. You bring that down to those common risk factors, and there are actually a few common risk factors which, if addressed, could potentially make a very dramatic impact on the disability adjusted life years. Yeah, thank you for that. Looking at the time, people now know your expertise, Felix, and they know of this study. and where to find it and where to find the data on the Institute of Health and Welfare site. So let's see what differences can be made to our resource prioritisation and our approach to health service delivery by better understanding what the burden of disease is. And as you say, we are looking to measure this far more explicitly in our region so that we can make better informed prioritisation of what are scarce resources. Thank you very much for really opening our minds to a different way of categorising our work, a different way of looking at our communities, and although not perfect, one that can help us in difficult decisions. I really appreciate the time you spent with us today, and appreciate the time that everyone who's attended and will look at this in the future has spent addressing these issues. So in Naranjari, Nakan, we'll see you all later.